All right, welcome everybody. We're going to get started here. Thanks for joining us tonight. We do expect some more to join us soon, but we also want to start right on the hour. So without further ado, I will jump into it. My name's Nate. I'm one of the members that organizes GOWME, the Global Organization for Wilderness Medical Education. So it's nice to see you all again here today. If this is your first time joining us, this is our mission. So what we aim to do is to really just create a space where we can showcase the really cool ways that students can get involved in medicine and healthcare after training. Most of our audience this year is students and residents. However, we also are proud to have participation from search and rescue technicians, PA students, nurses, non-medical people. So what we really aim to do is just to create a space where we can try to motivate and engage and excite people about all these really cool ways that we can get involved in subspecialties of medicine in our future practice. So if you haven't already, here's a QR code to join our mailing list. You can stay up to date on our lecture series. Next semester, we have a fellowship showcase. So if any of you are residents, this might be particularly interesting to you. I can say that last week we finalized our spring schedule. So I can say that that's going to be really fantastic. We have talks more on climate medicine, aerospace medicine. I think we have something on dentistry. So definitely stay tuned for that. It's going to be a great couple months after the holidays. We also have social media platforms. Our YouTube channel has a good amount of information on it. Most of our previous lectures can be found recorded on YouTube, so I would suggest for you to definitely check that out when you get a chance. This is also the last talk where we will be advertising this free swag giveaway. So Pit Viper has graciously offered to partner with us this year. They mostly have clothing, but they also, I believe, have ski gear and hiking gear. So if any of that interests you, to just remind you, it is free. So we'll drop a link to a form during this chat or this talk, and you can fill that form out, and your name will be added to the raffle. More housekeeping here. So we're still collecting applications for our e-boards. We've extended the deadline for another few weeks. So if you like what we do here and you want to help us out, and you're a student, please feel free to go on our website and fill out that application. Like I said, this is the last talk of the semester. So thanks for joining us, but stay tuned. We will return in about a month. So that brings us to our speaker for today, Dr. Ali Saad. Dr. Saad is board certified in neurology, stroke, and lifestyle medicine and has been practicing for over 10 years. He completed a fellowship in climate change and health policy at the University of Colorado's Climate and Health Program, where he is now affiliate faculty. Dr. Saad is also chair of the neurology member interest group at the American College of Lifestyle Medicine. His advocacy work focuses on poor diet being the leading cause of death and disability worldwide, while accounting for a third of global greenhouse gas emissions. So we have a great talk for you guys today on applications of climate medicine. If you have any questions during this lecture, please feel free to raise the emoji hand thing, or you can type your question in the chat, and we will have a Q&A session at the conclusion of this lecture. Lastly, if you're feeling brave, please feel free to put your video on. It's always nice, I think, at least for me, to have an audience where you can see everyone's faces. So with that, I'll stop sharing my screen and turn it over to you, Dr. Saad.
All right, thank you very much. Are you able to see my screen okay with the slides advancing?
I can see it. Yep.
Okay, very good. So this talk is entitled Climate Medicine, What Every Doctor Needs to Know. I have no relevant disclosures. And we should have captions generating at the bottom. If I think everyone can move it around at on their screen individually, but if it's obstructing things, please say so in the chat. All right, let me just minimize this. All right, there we go. So these are our three objectives for this talk. A lot of it in the beginning, I'm going to warn you, is going to sound terrible and apocalyptic, but I want you to just see this as data review or data presentation to give context for the solutions we're going to talk about at the end. And I'm going to provide a broad range of different ways for people to engage in climate advocacy. So I want to start with a primer to show how we know that climate change is real and caused by us. And this is a scale that shows carbon dioxide concentrations in the atmosphere in the y-axis and time in the x-axis, going all the way back to almost 1 million years. And there's a clear cycle you can see of having high and low levels of CO2 in the atmosphere. But in the early 20th century, we see that there was a significant jump in the amount of CO2 we were producing. And not only is it a big jump, but it also occurred at an unprecedented rate. We're all the way up to here. And so that's how we know that greenhouse gas emission increases are real and a driver of climate change. But you might say, maybe we're not looking back far enough. It might be part of a larger natural temperature fluctuation in the Earth over a longer period of time. So this is where data from ice core samples comes into play. So this is a scientist drilling for ice core samples. They'll go to the poles of the Earth or somewhere really cold like Greenland, and they'll drill this really long cylinder of ice. And similar to how rock and sediment form layers on the Earth over thousands and millions of years, ice does the same. And just how we can take a slice of Earth at a point in time and see the plants and animals that existed through the fossils, ice can be sampled in a similar manner. And the deeper down you go in the ice, the further back in time you're going, just like the Earth. And the cool thing about ice is that it's got these trapped air bubbles. So this is a cross section of an ice core sample. And when you sample the air bubbles, those air bubbles are representative of the atmosphere's composition at that point of time. And it's with these air bubbles that we can trend carbon dioxide concentrations in the atmosphere over time. But it's not simply the amount of CO2 that's stored in the air bubbles that's informative, it's also the type. So to refresh your memory, this is photosynthesis. And so plants take in sunlight and CO2 in the air. They convert it into carbon atoms that make up the bodies of plants. And what you may also remember, I didn't until I looked it up, the carbon occurs in three isotopes, 13, 14, and 12, 13, 14, sorry, named for the number of neutrons that the carbon atom contains. Plants prefer to take in C12 when they photosynthesize. And so when that plant dies, their body is still made up of mostly carbon-12. And when we burn fossil fuels, we release the trapped carbon in those plants' bodies into the atmosphere. Contrary to popular belief, fossil fuels are largely made from plants and plankton, not from dinosaurs. And so when we're burning those fossil fuels, we're releasing the carbon found in dead plants. And what we see is that around the time of the Industrial Revolution in the 1800s, that's when there was a relative shift in the amount of C12 to C13 in atmospheric carbon. And so that's how we know that the increased CO2 is coming predominantly from the bodies of plants and the burning of fossil fuels. That's how we know that it's us. And aside from CO2, there are other clues. So we've also had unprecedented rises in sea levels, in global temperatures, and also the length and severity of droughts. And this data is from the National Climate Assessment. This is a federal advisory committee that puts out data every year to tell us how we're doing in terms of climate change, and it provides health indicators, but also economic indicators. It's not specifically focused on health, but there's a health section. And just as an FYI, most of my slides have a hyperlink at the bottom, and if you click them, you can link directly to the source of the data. So I'd be happy to share a PDF of my slides at the end in the chat. So let's look at some examples of the mechanisms by which climate change affects human health. At 1.5 degrees Celsius rise in average global temperatures, we can expect that the homes of nearly 50 million people worldwide living in coastal cities and communities to be destroyed. And that 1.5 degree rise is equivalent to a 1.5 foot rise in sea levels. And of course, as the temperature increases further, once we get all the way up to 4 degrees, that rise can be up to 16 and a half feet. And that, of course, would decimate coastal communities and displace an estimated 760 million people, which is about 10% of the global population. And that's 10 times worse than the amount of people killed by COVID. And that's just due to sea level rise. We're not even talking about the other effects of climate change. And aside from sea level rise, we also have to think about temperature's effect on warming waters and the subsequent effect on coral. Coral is like the forest of the ocean in that it's where plants and animals eat, breed, and live. And so without coral, we have less seafood, which creates food insecurity. Those organisms also serve as a carbon sink because if you've got a lot of plants and animals in the ocean, their bodies are made of carbon, and so that carbon is sequestered in the ocean in that form. Aside from sequestering in organisms, carbon is also sequestered simply by the water and bodies of water absorbing the carbon dioxide, kind of like how Coke or Pepsi has carbonic acid. The CO2 from the atmosphere is pulled into oceans, and it makes the oceans more acidic. And so actually, about a third of the CO2 that humans produce is absorbed by the ocean. And so if we didn't have that mechanism of carbon sequestration, our planet would actually be a lot warmer than it is right now. And this acidification of the ocean is a problem because it interferes with the ability of coral, shellfish, and plankton to use calcium and synthesize their bodies and their exoskeletons. And because these organisms form the base of marine food systems, if there aren't enough of them and they're dying out, it causes collapse in the marine food pyramid. And this eventually translates into food insecurity in humans, especially communities like in Western Africa or Far East Asia, where they rely heavily on fisheries for their food and their economy. Delving deeper into food insecurity, currently about 66% of global calories rely on just a few crops. So wheat, soy, corn, and rice. And just a 1.5 degrees Celsius rise in average global temperatures is expected to decrease the yield of these crops by anywhere from 3 to 7%, depending on the crop in question. And not only do we have less crop, we also have less protein coming from these crops, and that's estimated to decrease by anywhere from 6 to 14%. Aside from protein, there's also micronutrients that are going to be lessened, specifically B vitamins, zinc, and iron, which will decrease in concentration in these crops. And this demonstrates a key vulnerability in our food system, where over-reliance on just a few crops that are susceptible to climate change is a problem, not only because it can decimate those crops, but it can also make those crops less nutritious. So if we're encouraging people to eat more plants, it's kind of a hard sell if those plants are no longer going to be nutritious. And lastly, water redistribution. So as global waters heat up, they evaporate faster than they can be replaced by rain. And that leads to more frequent and longer lasting droughts. And it also is difficult for the water to be replenished in our groundwater reservoirs. And that's the water we'll use to pump and irrigate our crops. And so these changes in water distribution also lead to more frequent and severe flooding and storms, which has been happening and is going to continue to worsen. And people will often cite this as evidence that climate change is not real or it's not that bad. I remember a few years ago, there was a politician during a snowstorm and he held up this snowball at a press conference and said something to the effect of, climate change can't be that bad. But in fact, the fact that we're having these increased wet and cold periods in terms of severity and frequency is actually accumulating in shorter periods of time. So that means that we're going to have more frequent wet events like rainstorms and flooding. And when they do happen, they're going to be more severe. So climate change not only causes more severe and frequent extreme hot events, but also cold events. And we can expect that as global temperatures rise, all of these natural disasters are expected to increase in frequency, but the ones that kill the most are actually heat waves, and they're going to be the most frequent. And they do this directly by causing heat stroke, but also indirectly by triggering people with underlying risk factors to have a stroke or a heart attack or renal failure at that around the time of that event. And so this brings me to the two main ways that our health is worsened by climate change. There's two main mechanisms. The first one is direct toxicity from pollutants in air, water, land, and food. So just think about air pollutants like PM 2.5. They're directly toxic to you. They cause health effects like asthma exacerbations, stroke, and heart attack in the long term. But the second mechanism is by exacerbating the social determinants of health, which are the main drivers of most chronic disease in the US and globally. And this second mechanism is nicely demonstrated here in this graphic from the CDC. So 6 in 10 Americans and 4 in will have or do have one chronic disease, and 4 in 10 Americans have at least 2 or more. That means that the majority of Americans are chronically ill. And when we see patients in the hospital or the clinic without at least one of these diseases, that's the exception to the rule. And these are the main diseases we're talking about. And for these diseases, these are the main risk factors. So these are all lifestyle risk factors. And what what we were talking about in the last couple of slides in terms of food insecurity, dirty air, dirty water, extreme temperatures limiting the ability to exercise outdoor, these climate stressors impede our ability to prescribe things like good nutrition and physical activity. And it also makes people more likely to abuse substances because of the stress caused by climate stressors and then economic hardships, separation from their families during climate disasters. So that's the relation and kind of the insidious relationship between climate change and environmental pollution in the long term for chronic disease. So let's zoom in on human health a little bit more. The magnitude of harm from climate change is no longer this like weird radical fringe position that you'll find in articles here and there on PubMed. It's now considered a mainstream position. So this is a statement by the WHO. Climate change is the greatest threat to global health in the 21st century. That's a really shocking and disturbing statement. And unfortunately, rather than doing no harm, healthcare is actively fueling the carbon fire simply by existing. So US healthcare is responsible for about 8.5% of US carbon emissions, while global healthcare systems are responsible for 5%, just by functioning as an industry. And even these small increases in emissions translate to deaths secondary to air pollution. And the scale of harm from air pollution is far greater than what most people are aware of. So here are stats published from an article in the Lancet Planetary Health. This is a journal that publishes specifically on climate and health and is a subsidiary of the main Lancet journal that most of us are familiar with. And it's mind-boggling that now pollution kills more than AIDS, TB, malaria combined, and more than all forms of war and violence. And it's getting worse over the last few decades. And most of it is happening in low to middle income countries. And so, the majority of these deaths we're seeing from climate change are not these people that are dying in a flood or dying in forest fires that we'll see on the news. It's insidious. A lot of these deaths will happen a few days after the heat wave or the wildfire or what have you. And what we'll see is a few days after that natural disaster, there's a spike in ER visits for people coming in with stroke, heart attack, respiratory failure, renal failure. And their diagnoses are coded as those diseases. They're not coded as complications of climate disasters. So epidemiologically, when we're trying to track this data, we're probably underestimating the number of people that are coming in with these diseases that they were predisposed to for the most part, but it triggered them to have them earlier in life and happened now at the time of the climate stressor. And it becomes even harder to track things that affect your disease risk in the longer term, things like cancer, things like birth defects. Here are some regional examples of climate-sensitive diseases. The gist of it is that as temperatures rise, summers become longer and hotter. And bugs and microorganisms love warm weather, they thrive in it. And mosquitoes and ticks are the main vectors for the majority of these diseases. So what happens is areas that were previously too cold for these vectors to live in are now accommodating because they're warm enough. And so the geographic spread of certain bugs and subsequently certain infections increases. But also because the summers are longer, the days in the year when it's considered tick season, for example, or Lyme season, that becomes prolonged. And so now we're seeing things like West Nile and Lyme well into the autumn, to the end of autumn, when previously that would be a weird thing, and we wouldn't even think to screen for it when someone comes in with a constellation of symptoms possibly concerning for those diseases. And of the climate-sensitive vector-borne diseases, Lyme is the one with the most definite increase that we can say there's definitely an increase in incidence. It's been corroborated by the CDC. Others like Vibrio and West Nile, they seem to be increasing, but different sources are, they're kind of, the jury's still out in terms of whether there's a definite increase. And what we're seeing with these other vector-borne illnesses is that the concern with them is mostly based on projections rather than real world data showing a definite increase. Another example is vampire bats. They're another vector species, and their ranges in Texas and Florida is expected to increase with rising temperatures, which translates into increased risk of exposure for rabies in humans. And understandably, people are very worried about climate change and it's affecting their mental health. And this is especially prevalent among younger people. So in this study from the Boston Children's Hospital, it shows that 75% of children were at least moderately worried about climate change if they weren't very or extremely worried. And only 25% were a little worried or not worried at all. But climate anxiety is not a privileged problem of wealthy countries. This global study looks at both the global north and global south, so you can see the list of countries here. And the red, orange, and yellow bars represent people, young people specifically, that are extremely, very, or moderately worried about climate change. And the percentage of young people that feel this way is anywhere from 70 to 90%, depending on the country in question. So, as with any stressor, populations with socioeconomic disadvantages and those who have been historically discriminated against and marginalized are going to face the brunt of the burden when it comes to climate-related health effects. And these populations are also more likely to live in what's called fence line communities. So those are neighborhoods that are adjacent to industrial facilities like farms, factories, power plants. So they're closer to where the pollution is happening. And here are some of the mechanisms by which equity issues arise in terms of climate vulnerability. So going clockwise, people living with disabilities will already have trouble accessing healthcare, but when infrastructure like roads are damaged by extreme weather events, it makes it even harder for them. And it also makes it harder for their families and caretakers because they're usually not going to leave them behind when an evacuation is needed because the power is down or there's flooding or what have you. And so it affects the people around them as well that have to stay behind and take care of them. Power outages will affect cooling and warm weather, resulting in more heat stroke and heat-related illnesses. Poor communities have less availability of mitigation measures under extreme weather, things like air conditioners, backup generators, redundancy in food systems, multiple modes of transportation when people need to get out or just kind of go about their day and do what they need to do. And so when disasters strike, they're less able to cope, and they also have less funds to rebuild the damaged infrastructure. Another great example of an equity issue related to climate change is something called the urban heat island effect, which many of you may have already heard of. But briefly, this is the urban heat island effect. Basically, when there are too many buildings and asphalt and concrete at the expense of green and blue spaces like parks, lakes, rivers, but also just trees lining the street and grass in your backyard, if it gets too hot, if you have too many structures and not enough green and blue spaces. So you look at temperatures in rural areas and suburban areas that will have parks, lakes, tree-lined streets, stuff like that, compared to somewhere like downtown where it's a concrete jungle and there aren't a lot of green and blue spaces. What happens is the heat gets absorbed by these buildings, by the roads, by the black asphalt, the sidewalks, and then it radiates back out into the environment. And then it continues to radiate out at night. And so when nighttime naturally cools things on a summer night, that is, there's interference with that happening in highly urbanized areas with not a lot of green and blue spaces. And so what happens is people turn on the AC if they have AC, and then that makes the outside temperatures even worse. And people who don't have AC just have to suffer, and they just it interferes with their sleep. And so just a few degrees can take a hot day to a dangerously hot day, leading to heat stroke and heat-related illnesses. So what does a heat-resistant community look like? The stuff that I mentioned. It's basically adding green and blue spaces over here, because trees not only absorb CO2, but they provide shade. And tree shade can lower the ambient temperature. If you're sitting under a tree compared to just walking out in the sun, it can lower it by up to 10 degrees Fahrenheit. And trees also slow down how fast rain hits the water, and it also anchors soil in place. So trees mitigate or help mitigate against flooding. And bodies of water are also great at absorbing ambient heat. So having green spaces and blue spaces is important for those reasons, but it's also important for our physical and mental health. When people live near green and blue spaces, we know that it's associated with lower all-cause mortality, but also cardiovascular mortality. And climate disasters are also super expensive. So the redder a state is here on this map, the more money that state has had to spend in the last year, in the last 4 years on climate-related natural disasters like floods, fires, hurricanes. So you can see that the coastal states are very vulnerable, which makes sense because geographically they're predisposed to those disasters anyway. But with climate change, these disasters happen more frequently and they're more severe when they do happen. But you can also see that here in the southeastern US, many of these states are among the poorest states in the country, and a lot of the counties within those states. And so these communities may not have the funding needed to create climate mitigation plans, like reinforcing their hospitals so that they're not destroyed by natural disasters, like what happened with Hurricane Katrina, having resilient roads, having resilient infrastructure to withstand extreme weather. They may not have the infrastructure and the money to mitigate against these things, and then also to repair and recover after these things happen. And we can also see the interaction of these factors on these maps. So this pink map shows us counties within each state that have a high social vulnerability index. And the way that's calculated is things like low income, being underinsured, crowded living spaces, limited transportation options. And then the blue map shows us pretty much what we saw in the last slide of climate vulnerable areas where states spend a lot of money on natural disasters. And so when you combine these two risk factors, that's a double whammy for people living in these counties whenever climate disasters strike. And here's another map correlating heat with income level. So in these three maps up here on top, the reddest areas are the hottest areas. And you can see that the reddest zones are the ones that are in the inner city, whereas the suburban areas tend to be not as hot. And then this bottom section of three graphs shows us two things. So average temperatures are on the y-axis and income level is in the x-axis. And the first thing it shows us is that average temperatures tend to be lower in higher income areas, but also the range of fluctuation for these extreme temperatures between very hot and very cold is less extreme in these higher income areas. So poorer neighborhoods will have higher temperatures, but also more temperature fluctuations. And another example of an inequity issue is exposure to air pollution. This is data from the American Lung Association, and they found that 1 in 3 Americans live in an area that has an unacceptable level of air pollution as measured by the EPA. And thinking back to fence-line communities, these communities not only live close to polluting facilities, but also with very little greenery in the area to absorb that excessive CO2. And in fact, people of color are nearly 4 times as likely as whites to live in a county with multiple failing air quality grades as determined by the American Lung Association. And I think this is a great website to refer to because here's an example of Texas. So they arrange the counties alphabetically and they provide a letter grade to each county. So you can go and see how well your county is doing, and then you can kind of delve deeper into the data by clicking on things. But aside from that, another granular way to look at the data on the site is you can toggle it and see for each county what is the number of people by certain risk factors that are at risk for health related or poor health outcomes. So this is helpful if I'm talking to a hospital leader or a local politician. I can say, hey, in your county, these are the number of constituents you have that have COPD or that are kids or that are over age 65, and they're predisposed to lung disease and other complications as a result of the unacceptable air quality in this county. And so this way I can reframe the discussion and not make it about climate change and make it more about health and provide real world data. And we don't need to wait decades to see the health benefits of climate change. In 2016, one of the most polluted counties in Pittsburgh shut down one of its largest coal processing plants. And within weeks, they saw an immediate drop in heart-related problems and ER visits. And this effect persisted for 3 years. And the control they used was the 3 years preceding the shutdown of the plant. And in fact, the University of Pittsburgh is now the leader or a leader in the field of sustainable healthcare. And they actually hosted the country's largest sustainability and healthcare conference called Clean Med this past year. So now let's transition and talk about the good stuff because they gave you a lot of like terrible stuff. And so really relating this back to healthcare professionals, what are our barriers to being climate advocates and how can we use our power? So as physicians and healthcare professionals, we are still a pretty trusted source among the general public. But the problem is we're not educated about climate and health at any level of training. And the data shows, at least from this medical student study, that students want to learn more about this. But the problem is the information is not on board exams when you finish residency. It's not required for renewing your medical license or maintaining your board certification. And then let's say that healthcare professionals are learning about it. Okay, so now we're aware of the information. What do we actually do with it? So that answer is going to differ for everybody. Some healthcare professionals make good politicians. There's lots of doctors and nurses and other healthcare workers that end up running for office and they can create new laws, which is great. Others become good administrators in medical education or in specialty medical societies like the American Heart Association or the American Academy of Neurology. And they can update medical guidelines and best practices to incorporate people first, climate smart solutions, like calling for a divestment from fossil fuels, like mandating that climate and health education be included in medical training. Some people become hospital executives and they can make their hospital system carbon neutral, or they can set up incentives for their employees to take public transport. So these are all awesome ways for us to get involved. And really the best way to figure out what your best climate action is using this Venn diagram. But of course, it's not specific to climate action. You can use this in any area in your life. So you look at three things. What needs to be done for the benefit of society? What are you good at? And what do you like to do? And you find the intersection. And by way of example, I'd like to walk you through the thought process and my journey and how I came to my specific climate advocacy. So, and I also want to leave you with something that I think that all healthcare professionals should be doing for climate and health. And it's something super easy that doesn't ask you to do much. So my story is after being an attending for about 5 years, I got to a point where I felt confident with the kind of patient care I was providing, and I needed a new challenge, and I wasn't sure what that thing was going to be. I also felt like I wasn't really helping people. So, as a stroke neurologist, I knew I was providing life-saving emergency treatment in the hospital, but ultimately I was sending people home to these environments where they were exposed to unhealthy foods and smoking and low physical activity and air pollution. And all of these environmental and social risk factors account for 90% of your stroke risk. For the most part, stroke is not a weird genetic thing or an accident. It's the same stuff that causes heart attacks. And so I became very interested in social determinants of health and more specifically food and the prevention of stroke and other chronic disease, but totally unrelated to climate change. This is something I was just doing as a doctor. And then one day I was just catching up with a friend by the phone, and she told me that the University of Colorado had this climate and health fellowship. And outside of medicine, I'd always been very interested in environmentalism. And, I'd been doing the same thing that any private citizen would do. I'd recycle, compost, take public transport, stuff like that, but totally unrelated to medicine. So I decided to do the fellowship and learn more about how climate change intersects with health a lot of the stuff I just talked to you guys about. And after completing the fellowship, I had to put everything in action. So I said, okay, how should I spend my time as a professional, my professional time in a way that would make the biggest impact on climate change's effect on health? So I went back and looked at the data. So this is our data on global greenhouse gases. And over 70% are from the energy sector. And the energy sector is basically industry, transport, construction. Those are the things that generate the most greenhouse gases by numbers. And so, logically, this would be the most important piece to tackle in terms of greenhouse gas emissions. So I have to ask myself, what avenues could I take to address this 73%? I could write review articles for medical journals. I could write op-eds for newspapers. I could start a sustainability committee at my hospital, provide public testimony for anti-pollution bills, and maybe I could help change some hospital policies and even laws. And I did do this work, and I continue to do this work because it's important. But there are 5 main problems I identified with this advocacy method for me specifically. So number one, personally, I found it boring and tedious. This was not the kind of stuff I was interested in doing. Even though it's important and admirable, it wasn't my strength. I just didn't enjoy it. Number two, I had to depend on people in positions of power to give the green light. So the most I could do with a senator or a hospital CEO is say, here is the data, pretty please, make this bill happen. It wasn't really within my control. All I could do was advise and advocate. The third thing was, as a doctor, the most influence I had in terms of divesting from fossil fuel was within the healthcare sector, but the healthcare sector only accounts for 5% of global emissions, which is important. It still translates to, lives lost, but it's still only 5% of global emissions. The fourth thing was this kind of climate and health advocacy was something extra that I had to do on top of my day job that had nothing to do with direct patient care. Even though it heavily influenced social determinants of health, it was hard to make that connection with patients and colleagues without, kind of really getting into it. And the fifth thing was that there was only so much that I could do on my own. I needed help. I really couldn't get other doctors to engage and help me because they either didn't think it was relevant or they just didn't have the time to work on climate and health. They had so many things on their plate, understandably. So then I went back and thought, okay, even though by the numbers, fossil fuel divestment is the most important thing to do, it's not something I'm very passionate about. It's not my area of expertise, and I don't feel like I have a ton of influence in that area. And it also seemed really peripheral in terms of my everyday practice as a physician. And it also wasn't accessible for a lot of my colleagues. So I thought, what's an area of climate change that has a direct connection with everyday medicine? And I went back to this, and that's how I came to food. So you see this in this pizza pie, the second largest chunk is agriculture and food systems. So here's a different way of slicing the data. And what we see is our food systems account for at least a quarter of global greenhouse gases. But when you throw in food waste and indirect emissions, it accounts for a third of global greenhouse gases just from our food and agriculture system. And how does it create these greenhouse gases? It's these red, green, and brown bars. And those represent direct emissions from ruminant livestock, like cattle and sheep, but also the inordinate amount of land we use to grow that feed and house that livestock, because that necessitates clearing forests to get that land for those purposes. And food goes way beyond just the math of carbon emissions and greenhouse gases, because of course there's the direct pollution we produce from manufacturing foods. So think like smokestacks and factories over here. But then we're also using half of the habitable land on Earth just to grow our food, which in turn we feed to animals, and then we eat the animals. And then that destroys forests. We deplete the majority of our fresh water to irrigate our food. Our farming system results in eutrophication, which is basically the huge volume of manure and fertilizer dumped from our factories and our farms, ends up on our waterways and promotes the overgrowth of algae. These algae deplete oxygen levels in the water, making it uninhabitable for marine life. And so it creates dead zones where there's no plants or animals in that body of water, which happens in parts of the Gulf of Mexico. This overgrowth of algae also causes direct toxicity because some of these algae will have other microorganisms that create neurotoxins that are not killed by high temperatures. And we end up ingesting them by eating shellfish. So I thought, wow, food is involved in so many aspects of climate change, and it goes way beyond carbon emissions. And, so that's the climate piece. But from the health piece, I learned that most deaths in the world, according to the Lancet's Global Burden of Disease study, are attributable to too much processed food, not enough whole grains, not enough legumes, not enough fruits and vegetables, basically not eating enough plants. And it does this by fueling our common chronic diseases, which then lead to mortality. So these are our most common chronic diseases globally per the WHO. So most of our diseases are these blue diseases, which are non-communicable or non-infectious. And with the exception of lung disease, all of them are influenced by diet, as well as other lifestyle risk factors like exercise and sleep. But diet is a huge one. So here, heart disease, stroke, uh, you know, lung disease is mostly from smoking, but then Alzheimer's, diabetes, and kidney disease as well. All of these non-communicable diseases. The green ones are the more infectious ones. And what we see is over time, as countries become industrialized over the last 20 years, they get more of these lifestyle diseases and less of these infectious diseases. And in fact, the American Society for Nutrition has declared across all preventable risk factors for disease in the US, poor diet is now the leading cause of disease, associated with more than 500,000 deaths per year. So even if I didn't care about climate change at all, food should be my biggest focus to prevent disease across the board as a healthcare professional, especially when I'm specializing in a lifestyle related disease like stroke. But it also happens to be our second biggest greenhouse gas emitter, our food systems. So there's a significant climate co-benefit that we can address by focusing on food systems for the promotion of human health. Um, and it also, by promoting healthy food, we're disrupting the positive feedback loop that an unhealthy food system creates on an unhealthy environment, which in turn worsens our chronic disease through air pollution and other forms of pollution. So not only is food the second biggest creator of global greenhouse gases, but projections suggest that even if we got rid of all fossil fuels today, our current food system alone would jeopardize being able to stay below that 1.5-degree target of average global temperatures, which is one of our major climate tipping points. That means if we don't fix our food system, all the divestment from fossil fuels and all the effort in that arena is not going to cut it in terms of meeting our Paris Climate Agreement goal. And the reverse is also true. Addressing food systems alone could be enough to keep us below the 1.5-degree target, even without significantly addressing our fossil fuel problem. And this was the conclusion reached by the Eat Lancet Commission. So this is a study that was commissioned to do the math and figure out how can we feed a projected global population of 10 billion without destroying the planet. So that's how I found my Venn diagram and my climate advocacy, because it made sense with my specialty. It was something I was interested in, but I also thought it was a way for me to engage colleagues and reframe it and make it about patients rather than climate change. Because this way I'm bypassing convincing people that climate change is real and explaining the connection between climate change. I didn't really need them to care or know about climate change. I just needed them to focus on healthy eating and promoting reduction in chronic disease for our patients. So this was kind of an indirect climate advocacy that was accessible to healthcare professionals of all backgrounds, regardless of their specialty, their geography, or their political affiliation. So what's a healthy diet look like? This is the dietary recommendations recommended by the American Heart Association. And broadly speaking, the themes of this diet are that most of your food should be minimally processed, not a lot of ultra processed food, and predominantly coming from plants. When you do eat animal products, you should choose the ones that don't have a lot of saturated fat. And this is concordant with most dietary guidelines for most chronic diseases in most countries. Everyone's kind of saying the same thing. They might recommend something like, like a Mediterranean diet or a DASH diet, and they all kind of promote the same themes. But that same diet is also the most sustainable diet from the planet's perspective. So this is from the Eat Lancet Commission that I had mentioned earlier. To sustain a secure food supply for a population of 10 billion, the Eat Lancet Commission did the math and found that the average person should consume no more than 2 servings of animal products a day. 1 serving of dairy and 1 serving of anything else, except red meat, because red meat should really be consumed up to once a week because it's more greenhouse gas intensive than things like seafood, poultry, etc. So what does that look like in a typical person's day? That's going to mean You're going to have cereal with milk in the morning, or yogurt with something in the morning. You'll have a salad or a grain bowl for lunch, and then you'll have chicken or salmon or something with some veggies and rice or some pasta in the evening. It's not a very restrictive diet. It's very accessible, actually. And that's the average that most people should be doing. A lot of people don't even eat that many animal products. So here's some data on emissions from different diets. This first graph over here is our current diet, and you can see that this red chunk, which represents red meat, creates the most emissions. And this second graph is the national dietary guidelines in the US. And just by following the national dietary guidelines and reducing red meat, not eliminating it, just reducing it to the recommended amount by current dietary guidelines, we actually will sequester carbon by promoting green spaces, because we won't need as much space to grow the feed to feed these cattle and these sheep. And looking over here, we have about 600 versus about 700 over here. So we're actually slightly carbon negative just by following the national dietary guidelines. And we're sustainable. But then in order to feed 10 billion, we have to be more aggressive. And so we go to this Eat Lancet diet, which reduces red meat even further. It doesn't eliminate it, but reduces it. And now we're definitely carbon negative, which is great. And then when you compare the Eat Lancet to other diets like pescatarian, vegetarian, vegan, they kind of play around with the proportions of foods you're eating, but ultimately you're still promoting these green spaces that are now freed up and left to become the natural forests that they were and be rewilded because they're no longer being used for farmland. And I think among all of these, the Eat Lancet is probably the most inclusive for people that don't want to be vegan or vegetarian or pescatarian. And it's really the bare minimum that we need to do, and it's acceptable and sustainable. And then when we look at the mortality, it's kind of the same patterns. We get the most reduction in mortality transitioning from our current diet to the Eat Lancet by, again, not eliminating, but reducing red meat consumption and replacing this red bar with more of the gray. So red is red meat, gray is legumes. So they're basically plant meats, and that I don't mean like Impossible Burgers, but I mean the plant equivalent of meat, and that they are sources of high protein and high iron. So things like beans, lentils, legumes, nuts, and seeds. And so just by doing that, we're reducing mortality. And again, you make more gains with vegetarianism and veganism, but just by following the Eat Lancet, we are reducing the bulk of our mortality. And so this is the last slide. I don't want you to think of climate medicine as saving the planet. That's not the goal of climate medicine. It's not about saving the planet. It's about saving people. And it's about recognizing that the problems and solutions that are causing human and planetary health to be unwell are one and the same. And in modern healthcare, what we're currently doing is we're mopping up the floor without turning off the faucet. This is a common analogy we'll use in preventative medicine. And I think it's why when we do surveys of students in healthcare and medical residents, they're reporting higher levels of burnout than previous generations. And it's not because they're weak. I think it's because they're smart and they see the writing on the wall, and they're seeing that we don't have healthcare. We have for-profit sick care. So make no mistake that if you're in healthcare, climate medicine is going to be a significant part of your life, and it is absolutely within your lane to advocate for. And there are so many ways that you can get involved. All of them are free. So the first one I like to mention is right here. I'm wearing this little badge called Climate RX. You can go to that website through the QR code, and they'll mail one to you. And it's something you can wear in kind of low stress environments like clinics rather than in the hospital, for example. You can wear it when you go to medical conferences, or you're just at the airport on the train. People will see it and be like, "Hey, what's climate medicine?" And sometimes they'll scan it, but most of the time they don't scan it. It's an icebreaker, and it's a conversation starter, and allows them to learn about climate and medicine. I just talk to them for a couple minutes and answer any questions they may have about it. So this is a great way to kind of increase awareness. A second way that's relevant for students, and I thought it would be good for this audience, is there's something called the Planetary Health Report Card. This was started by medical students, and it ranks med schools on how well they are teaching about sustainability in their curriculum, and it provides letter grades on various aspects of their using a scoring system. But they also provide free resources on teaching about climate change and health. And this other resource, Climate Resources for Health Education from Columbia, it also provides free resources. So you can go on their website and say, I want to look up kidney disease or I want to look up lung disease. It can provide free modules that you download with a facilitator guide, a PowerPoint that you can just have a faculty member use during an elective to talk about, lung disease and air pollution or, heart attacks or stroke or whatever related to climate change. And then if you like to get involved on an advocacy level, I encourage people to join the Medical Society Consortium. You can join as a individual, as a state, as a medical society. It's for free, of course. And basically, the Medical Society Consortium has about 50 medical societies in it and about 20 state chapters. And these medical societies represent 70% of physicians in the US. And what they do is they work with grassroots organizations based in states, and they connect them to the medical society office. And you go to DC, and then you can meet on the Hill with people representing your state and talk about climate change and help argue to sponsor certain climate bills that are important for health. And then it also helps you establish relationships for when you want to meet off the Hill. But for people that don't have the interest to work on climate in these very specific and specialized ways, like I said earlier, the best thing you can do for your patients is to promote healthy eating, active transport like walking and biking, allowing and encouraging people to spend time in nature for their physical and mental health. Not only by counseling people to do all these things, but also advocating for policies in your school, in your residency, in your hospital, in your city and state, in your country that promote these policies in order to make it easier for people to do these things and for healthcare professionals to prescribe these things and treat the underlying reasons for the bulk of our chronic diseases. Because what we really need to do is zoom out and see healthcare not through the lens of individual outcomes, like a patient's lipid panel or their blood pressure, but by the environment that they live in that predisposes them to have these issues to begin with. So here's my contact info. Thanks for allowing me to talk to you guys today. I can put a PDF of my slides in the chat, and I'm happy to take any questions you may have. None are offensive or silly or divisive. I'm happy to answer anything. I'm open to criticism, and I want to learn from you guys. Thank you.
Dr. Saad, thank you so much. I might just be speaking for myself, but at this point, I've listened to maybe a dozen lectures on climate change in medicine. Thankfully, my school does have some presentations on it, but this just felt, you were right. It started out bleak as it should, but just like very refreshing. I thought it was great to listen about your path and how you were able to, here at GOWME, we're really big about the passion piece, right? We show things on like ski medicine and stuff in space. That stuff it's very glorious, but like to see that you take that Venn diagram and apply it to your own life, I thought that was just, that was just really cool to see. So I have a couple questions, but at this point I will open it up to the group. Feel free to unmute yourself, or if you can't do that right now, you can drop a question in the chat. We have maybe 5 or 10 minutes to answer questions here.
Hi there.
I'm
This is
uploading the
John.
PDF right now. Hey.
Hi there, Dr. Saad. This is really awesome. I am a classmate of Nate's, and so he encouraged me to come to this. I'm also really passionate about lifestyle medicine, and I started an LMIG at our university.
Oh, great.
But something that I kind of struggle with, and I don't know if it's because of apathy or people just being so busy, is that it's really hard to motivate like classmates and to a maybe lesser extent like administrators and our professors to not only take this into account in the curriculum, but also practice what you preach and preach what you practice. And I'm just curious, like, what your thoughts are on kind of motivating change in our physicians to like adopt these kinds of behaviors, because you wouldn't want to go to see a doctor who's a smoker, but our environment sort of lends itself towards a diet that's really not ideal. So just curious, like, how do you motivate your students and and your peers to kind of like take this more seriously? Thank you.
Sure. No, of course. So, I mean, it kind of depends on what you're aiming for and how you want to approach it, because there's the carrot method, there's the stick method, right? But before I get into it, I also want to mention that the American College of Lifestyle Medicine, I'm on their Global Sustainability Committee. And at our last annual meeting, we actually had a plenary session talking about the intersection between lifestyle and planetary health, and really encouraging the healthcare professionals that were doing lifestyle medicine, telling them, you guys are doing awesome work for your patients, but you're also doing all these awesome climate co-benefits that you're probably not aware of. And really framing the message as, we don't need you to do anything extra. We don't need you to do all this extra stuff for climate change. Keep doing what you're doing and do more of what you're doing for lifestyle, because it's helping your patients and it should be about your patients, but you're also doing awesome things for the planet, and here are the connections. So I think, whenever I'm talking to anybody, I want to first determine, am I the right messenger to talk to this person, right? Like, am I going to be believable? Because I could talk someone's ears off and give them credible data and align with their values, but if they don't trust me, I'm not going to be the right person. So, your first step might actually be to identify someone else to approach them if you're not the right person. The second thing is, if you are an acceptable messenger for the person you're speaking to, then it becomes aligning with their values and thinking, okay, what does this person care about? What is stressing them out? And what are things that they're already working on? Because, as you progress through your career, you're going to get busier and busier, and people are going to be just like snatching bits of your time. And so it's much easier to incorporate something that someone is already working on or they want to work on, and showing them that there are these co-benefits, rather than adding them to add something else to their plate. So, for example, when you're talking to a hospital administrator, one of the most important things for them is patient satisfaction and also the bottom line. And so what you can show them is data about how creating a health system that has green sources of energy, they are going to be less susceptible to disruption of operations in the setting of a climate disaster if they have alternate methods to fuel their health system. They're also not going to lose money from having to shut down their hospital and lose elective surgical cases if they create a hospital that has, barriers against high tides, barriers against hurricanes, so that their operations aren't disrupted. So you make a financial argument. When you're talking to medical educators, you can appeal to statements from the American Medical Association or other societies that show that climate and health is important, but that also it's coming down the pike and that it's going to be incorporated into ACGME guidelines in a few years, and showing them, hey, this is an avenue where you could be ahead of the curve, and we could start having didactics on this, and it's something that we could advertise to prospective residents or medical students for our program, to show that we're progressive and we are in line with AMA guidelines. So just really leveraging those values and asking people not to do anything extra. That's what I found most helpful.
Dr. Saad, I have a question. Also, I see your PDF is in the chat here. With your permission, I would love to send that out on our email.
Oh,
Or at
please
least
go ahead.
I was thinking the last slide in particular, like ways to get involved.
Mhm.
I think that would be great. So I'll send that to our audience. On the same theme of communication, in my experience, I've found that a lot of my peers, especially, I think maybe Gen Z, like those in high school right now, maybe early college, there's I've detected like this overwhelming culture of nihilism and
Mhm.
kind of just resignation to our fate. Um,
Mhm.
so I could tell from like your presentation um, that I saw ways how you were able to counter that with realistic ways to know yourself and know how you fit into the larger picture to contribute in your own unique way. But how do you communicate with your patients who also feel, I guess, just defeated and nihilistic about climate change and all that stuff?
Yeah. So I think a lot of people think about climate change in a very black and white way, where they'll say, oh, like we're 66% certain to exceed the 1.5 degree threshold. So what's the point, right? But that's really not the right way to look at it. The way to look at it is I like to use stroke as an analogy because as soon as someone's stroke starts, neurons start dying. And even if someone gets to the hospital within a few minutes and they're treated within a few minutes and you get an MRI and the MRI shows no evidence of stroke, there's always a little bit of brain damage because a stroke is like a forest fire. The quicker you get to it, the more forest you save, but there's always a little bit of damage. And so the way to think about it is we're not trying to aim for perfection. We want, if we're projected to get to 1.7 degrees, getting to 1.6 degrees is going to save millions of lives. And so that's really the way to think about it. It's not about perfection. It's about doing the best we can and getting as far away from those climate thresholds as we can, because every tenth of a degree saves lives. And so that's really the way to think about it. And making that analogy when I'm talking to health professionals, because a lot of times when we're dealing with various medical conditions, we're not aiming for perfection. We're aiming to get them better. We're trying to make their diabetes better. We're trying to get their cancer into remission. We're trying to give them more years. We're not trying to keep them alive forever. We're not trying to aim for perfection. So I think we kind of reframing our goal is really important. And then also, even if we reach these climate thresholds that are really terrible, it doesn't mean that the world is going to explode, right? What it means is that life is going to be more inconvenient, food is going to be more expensive, and the people that are going to suffer most are people that already have food insecurities, financial insecurities, are living in low and middle income countries. It's going to make everything worse, but it's not that the world is going to be destroyed necessarily. So it's again, it's looking at it in a non-binary way. And then also really focusing on the health outcomes, right? Because if you make all these health changes and it's only within the confines of your particular hospital system, you are directly helping patients by promoting active transport, by healthy eating, by having your hospital no longer invest in fossil fuels. You're helping people in your community and saving their lives and keeping them from getting cancer and getting lung disease. And really bringing it back to public health and patients rather than the state of the planet as a whole. Because there's only so much we can do, right?
Yeah, absolutely. All right. We're a little past the hour. If anyone has any questions, please speak up now. But if not, I think we'll wrap it up here. So, Dr. Saad, thank you again so much for that amazing talk. I'll send out a couple of those slides on our next email for everyone to see. And aside from that, we look forward to resuming our talks in about a month from now. So we'll end it there. I hope everyone has a good night, and thanks again for joining us tonight.
Thanks, everybody.
Thank you.